Chunyu Cai MD PhD, who goes by Dr. Hunter Cai, is an associate professor in the Department of Pathology at UT Southwestern Medical Center. Dr. Cai specializes in neuropathology, including the diagnosis of muscle and nerve biopsies, brain and spinal cord biopsies, and brain autopsies. One second. Dr. Cai earned his medical degree at Peking University Health Science Center in Beijing, China. He completed a residency in anatomic pathology and fellowships in neuropathology and surgical pathology at Barnes Jewish Hospital and Washington University in St. Louis, Missouri. Certified by the American Board of Pathology in Anatomic Pathology and Neuropathology, he joined the UT Southwestern faculty in 2015. He is Associate Program Director for the Neuropathology Fellowship Program and Director of the Neuromuscular Pathology Service at UT Southwestern. Dr. Cai's research focuses on neuromuscular diseases and brain tumors. He has delivered national and regional invited lectures, edited and contributed to the book, A Case-Based Guide to Neuromuscular Pathology, and published numerous academic articles related to his areas of expertise. He is a member of the American Association of Neuropathologists, including its educational committee. He serves as associate editor for laboratory investigation and deputy editor for neuropathology for pathologyoutlines.com. He's also on the editorial board of the Journal of Neuropathology and Experimental Neurology. And I'm really looking forward to this talk.
Thank you. Thank you, Dr. Olivia, for the general introduction. I'm very grateful and excited to be given the opportunity to present this topic to you today. So the topic is crafting a meaningful muscle pathology report, dermatomyositis and its mimickers. I have no relevant disclosures. So there are three topics I'm going to cover today. First of all, I'm going to talk about the antibody-specific subtypes of dermatomyositis. And then I will describe five major differential considerations that can look or can have a periphysical injury pattern. And then thirdly, and I will present to you that neuromuscular pathology reporting is quite different from general surgical pathology. And it has rarely been talked about, and I'm going to discuss the most essential qualities of neuromuscular pathology report. And so for neuromuscular pathology, there is no worldwide consensus guideline like the WHO tumor classification for brain tumors. The closest consensus guideline for neuromuscular pathology is from the European Neuromuscular Center international workshops. So the ENMC, they hold these international workshops twice a year, and they invite 20 to 25 experts in the field, those including clinicians, researchers, patients, and industry representatives. And they discuss the state-of-art findings for a particular disease, and they put their findings or discussions in a paper published in the Journal of Neurological Disorders. And occasionally they would publish diagnosed guidelines. And these three listed here are most relevant to dermatomyositis and also inflammatory myositis. So those are my major references here for international guidelines. So for idiopathic inflammatory myopathies, the ENMC currently recognizes four major types: dermatomyositis, antisynthetase syndrome-associated myositis, immune-mediated necrotizing myopathy, and inclusion body myositis. So these four subtypes by no means cover all the inflammatory myopathies that you can encounter on muscle biopsy. However, they can be set aside by from all the others by these myositis-specific antibodies, which are listed in the tables here. And there are 5 for dermatomyositis, 2 for immune-mediated necrotizing myopathies, and 8 for antisynthetase syndrome. And there's an exception for this CN1A, also called NT5C1A. It has been used as a marker for IBM, but it's less specific, and it's not completely it's less specific and it's less sensitive. But in general, myositis specific antibodies are considered mutually exclusive to each other, and they're specific for a disease entity. So if, say for example, if we have NXP2 for myositis, it can be determined as dermatomyositis. And MSA testing is generally preferred to be done before any immunotherapy was performed. So specific to dermatomyositis, this is the 2019 AANP diagnostic criteria. This is a clinical diagnosing criteria which included pathology. So basically, there are three ways that you can reach the diagnosis of dermatomyositis. Dermatomyositis type of skin rash, so that's the heliotrope rash around the eye and Goldrum papules on the back of the hands. So you can have the dermatomyositis type of rash plus a skin biopsy that shows interface dermatomyositis. So these mostly are for the amyopathic dermatomyositis patients to reach a diagnosis. And then you can have the rash plus muscle pathology with supporting findings on the muscle biopsy. And then third way is if you have a rash and myositis specific antibody in the serum. So relating to the pathology criteria, there are two definitive criteria and then two suggestive criteria. The definitive criteria are perifascicular atrophy or perifascicular mix A overexpression as shown in the figure. So this is a perifascicular atrophy, usually uniformly involving fascicles along the full length of the fascicle. And then this is a mix A expression in myofibers. So it's the myofiber expression that's important, not the capillary or inflammatory cell staining. And so I want to point your attention to, they have this qualifying phrase with rare or absent necrosis. So at the time, presence of necrosis in this perifascicular region or elsewhere is considered a feature that argue against dermatomyositis. As you'll see along this talk, it's no longer true. And then the suggestive features are basically there's a perifascicular injury pattern that can represent it as loss of COX expression or positive NCAM positivity. That's a regenerating fiber marker. And also probably not mentioned here is the overexpression of MHC class 1 in these perifascicular fibers. And then the lymphocytic inflammation is typically showing a perivascular pattern. So these are relatively less specific findings you can see in a lot of other conditions. So getting into the specifics, so there are 5 dermatomyositis specific autoantibodies, and we start with this MI2 subtype. And pathologically, this is distinct by itself. It has a very prominent perifascicular necrotizing pattern as shown in the picture here. So you can see these very washed out fibers, they are necrotic fibers and they lie along the paramecium here. You can also see regenerating fibers. And there is no obvious smooth perifascicular atrophy here. You can have some atrophic fibers, and those are mostly composed of regenerating fibers, and they're interspersed by normal sized fibers. Clinically, this variant is characterized the most severe weakness among all the dermatomyositis patients, and they have the highest CK and often more than 10,000. And there is a tight CK and MI2 titer correlation, as you see in this figure here. So this is from my own study in juvenile dermatomyositis patients. The patients with high titer of MI2 has very high CK levels, and patient has low titer, has low or normal CK levels. And necrotic fibers and regenerating fibers can be better highlighted by these immunostains. So this C5b9 is also called terminal complement complex or membrane attacking complex. So the strongly stained fibers with sarcoplasmic stains are necrotic fibers. So you can see they have this general distribution along the paramecium. And the paramecium is highlighted by this black lines here. And the alkaline phosphatase shows this dark connective tissue stain, which indicate connective tissue damage, and also highlights all these regenerating fibers and necrotic fibers in this involved zone. MHC class 1 typically shows a perifascicular accentuation. They can be either only positive in perifascicular fibers, or they can be a diffuse positive pattern with increased staining in perifascicular fibers. MHC class 2 is typically negative or very weakly positive. And mix A, or myxovirus resistant protein A, as its full name, is currently considered a specific marker for dermatomyositis. And you can see that these perifascicular fiber has strong sarcoplasmic reactivity. The second morphologic type comprise the NXP2 and TIF1 gamma autoantibodies. So histologically, it's very difficult to separate these two. And in the very early stage, you see this, what I call basophilic vacuolar changes. So you can see a lot of these fibers are basophilic compared to normal fibers. And you can see a lot of vacuoles forming in these fibers. And this is typically at the very early onset of disease, and you don't see a good formation of perifascicular atrophy yet. And as the disease goes on a little bit more, and then you can see this perifascicular atrophy pattern that develop that usually span the full length of the fascicles. So clinically, the clinical phenotype NXP2 and TIF1 gamma are different. NXP2 is the most common juvenile dermatomyositis autoantibody, but it can also be seen in adults. In the juveniles, it's typically associated with GI bleeding and calcinosis as a fairly unique features. And in the adults, it's associated with underlying malignancies. And for TIF1 gamma, this is the one that's more common in older people, and it has the highest association with malignancy. And one of the phenotype that these patients have that is more prominent than others, the dermatomyositis subtype, is dysphagia. And you can see this serum correlation here, and that applies to both NXP2 and TIF1 gamma, is that there is no correlation between the antibody titer and CK. So here you can see the high titer NXP2 patient, their CK ranged from all the way from normal to 4,000. And this high CK can also be seen in low titer patients. So there is no correlation whatsoever. And MHC class 1 typically shows this, again, the perifascicular upregulation. MHC2 is typically negative or very weak. Mix A shows this strong perifascicular myofiber staining as shown here. The most useful staining in telling NXP2 and TIF1 gamma from all other type is the C5b9 staining. So you can see there's no necrotic fibers in this field, but there is very prominent capillary staining. This capillary staining is patchy, so it's not the same everywhere. We'll see it on the digital slides later, but when it's present, it's very robust. And in the NXP2 patients or TIF1 gamma patients, the CK can be high. When they are high, that's usually because they have infarct. Because this disease is an attack on the capillary and small vessels, and they can cause muscle infarct. And when the infarct happens, you can see that this is a very well circumscribed region, and there's confluent necrosis in this region. And it has a roughly round shape that is corresponding to a vascular territory. And also note in the background, you can see this pretty robust capillary staining surrounding this area. And this is the alkaline phosphatase. Alkaline phosphatase typically shows very little connective tissue reactivity, but they can highlight these zones of infarct. And here, just a brief mentioning infarct versus perifascicular necrotizing myopathy. So they can be similar sometimes, but there are important differences. So this is an actual infarct pattern that you just see. And they can also have a border zone infarct pattern. That is, they have this kind of concave shape. These are the C5b9 positive fibers, and they are between the vascular territory. So immediately surrounding these blood vessels, the fibers are are viable, and the fibers that's most distant to the nearest vessel, they are the dead ones. So this is the typical border zone infarct pattern. And here is a perivascular necrotizing pattern that you see in the MI2 variant. Here you can see the necrotic fibers actually track along the perimysium, but they don't cross it. And the border zone infarct, they don't actually respect the perimysium. They directly intersect it, and they more kind of surrounding these vascular territories. All right, the third morphologic group that would include both the MDA5 and the SAE group, that is the normal or near normal group. And histology can look completely normal, just like this. And so clinically, the MDA5 patients, they are characterized by mechanic hands, skin ulcerations, and very severe and rapid progressive interstitial lung disease. Their muscle weakness is often very mild. So that's why they're called amyopathic dermatomyositis. CK can be normal or just mildly elevated. And they are not associated with malignancy, but they have the worst prognosis because the interstitial lung disease is very hard to control and usually the cause of death. The SAE is much more mysterious. It's very rare. It only occurs in adults, and the muscle pathology in these patients are often very minimal. And here is a case of MDA5. So you can see here there's very subtle upregulation of MHC1 in the perivascular region. And mix A, when it's positive, it has this kind of scattered mosaic pattern, not perivascular. And it can also be completely negative. And here is a summary of this 5 subtypes, serological subtypes. What you need to remember is that there are 3 morphologic subtypes. The MI2 is characterized by perivascular necrotizing myopathy, and it has the highest level of weakness and CK level. The NXP2 and TIP1 gamma has a perivascular atrophy pattern, and also they have this vacuolar basophilic changes, and they are associated with cancer. And MDA5 and SAE, those are the ones that can have normal or near normal muscle pathology. And here, let's look at some actual digital slides. Let me bring up my image here. So I'll start with this case. So this is an NXP2 case. So at very low power, you can appreciate foci of inflammation. These are perivascular inflammations. And as we zoom in, you can, at this level, you can start to appreciate perivascular atrophy. So you can see that they span the full length of these fascicles, and they're very uniform. And towards the center, the fibers become bigger. And here's something that I learned from Pestron's lab that's very useful, and it's rarely mentioned in literature. That in the muscle, you have vascular perimycin and avascular perimycin. So here you can see the perimycin has no vessel. Here it has vessel. And the perivascular atrophy almost always happen in the avascular perimycin. So here you can see whenever you see it, it's flanking a region that doesn't have vessel. And when you have blood vessel, and you will not see perivascular atrophy. So this is actually a pretty useful feature that has been very rarely talked about. And as we further zoom in, we look at these actual myofibers, you can see a lot of these vacuolar changes and basophilic changes in these vessels. In these myofibers. Here are some larger vacuoles. Okay, and the most useful staining in setting them aside from other ones is this NXP2 staining. So NXP2, the C5b9 staining, the terminal confluent complex. So here you can see that there are very robust capillary staining, And this staining is quite patchy. So in this area is very strong. In other areas, it can be completely negative. And you can see it in multiple locations. And in the perimysium, it typically has a very granular punctate staining pattern. Another thing that you'll notice that they can highlight these infarcts, as you've seen in the pictures early on. The MI2 variant is quite different. And here you can see an example of MI2 variant. So in uninvolved area, it can look completely normal. And then in the involved area, it's like a nuclear bomb have been thrown there. It's very massive destruction. And if you look closely, you can see all these necrotic and regenerating fibers. They kind of track along the perimysium. And in some areas, they can expand more interiorly, so they have a more nodular kind of distribution there, but generally still follow the perifascicular distribution. And if you look at the C5b9 staining, there is minimal capillary staining, even in the area with massive necrosis. And when you look at these necrotic fibers, the acutely necrotic ones are strongly positive for the sarcoplasmic staining. And then you can have viable fibers that's abnormal. They have this granular C5b9 staining, and they are more concentrated in the perifascicular region. And if you look closely, these necrotic fibers, they tend to occur near vessel. So here's a vessel right here, and there's a vessel right here. And you can see that these necrotic fibers, they actually track along the vasculated perimysium. So that is different from the NXP2 variant. And same thing as up here. Here's another focus of perifascicular necrosis, and you can see it's located nearby a vessel. Okay, so let's get back to our presentation. Sorry. All right, so now let's talk about the differential considerations. I'm going to talk about 5 of them. Antisynthetase syndrome, lupus, myositis, scleroderma, eosinophilic fasciitis, immune checkpoint inhibitor, myositis. The first one is antisynthetase syndrome. So clinically, the hallmark is myositis, polyarthritis, and interstitial lung disease. They may not all be present at once. The more recognizable features on the skin are these so-called mechanic hands and Raynaud phenomenon, but they can also be seen in other rheumatology conditions. And important, these patients, they also can have Goldrum papules and heliotrope rash. So clinically, they can very much mimicking dermatomyositis patients. Laboratory feature CKs are typically high, more than 10 times the normal value, and they would have the antisynthetase syndrome antibodies. And the pathology is the perifascicular necrotizing myopathy. On low power, you can appreciate a level of atrophy in the perifascicular region. And on close up, you can see all these necrotic fibers and regenerating fibers. Again, this can be highlighted by MHC class 1, which has a very strong perifascicular staining pattern. And similarly, the alkaline phosphatase, just like the MI2 variant, they can have strong staining in the connective tissue. This is C5b9, which highlights the necrotic fibers. So there are typically very little capillary staining. This case shows some, but usually it's a very equivocal or weak. And they can have these pretty restricted perifascicular necrosis pattern, or sometimes you can also see them in the middle of the fascicles. And this is a case that there's prominent sarcolemmal staining in the viable fibers as well, which has a perifascicular accentuation here. The antisynthetase syndrome actually are pretty easy pathologically to differentiate from dermatomyositis, and there are multiple ways to do that. One is this mix A, which are typically strongly positive in dermatomyositis, but negative or very weak or only weakly blush in the necrotic fibers, like the Jo1 case here. And MHC2 shows exactly the opposite pattern. MHC2 typically negative or weak in dermatomyositis and strongly positive in antisynthetase syndrome. Now, if you don't have these two antibodies, you can use more traditional ways of EM. And so for dermatomyositis, both the MI2 variant and XP2 variant, they will have very frequent and easy to find endothelial tubular reticular inclusions. Antisynthetase syndrome, usually these inclusions are very rare or absent. And occasionally you can see these intranuclear filamentous inclusions. So these are actin filaments. These are pretty rare events. I have more than a dozen antisynthetase syndrome cases. There are only one case I found this, but it has been reported. And going on to lupus myositis. So lupus myositis is another systemic disease that can involve muscle. They're characterized by this malar rash and discoid rash that's quite different from dermatomyositis type rash. And clinically, they're quite different. They can have kidney involvement. They typically have lymphopenia or anemia, and they can have this pleuritis and pericarditis rather than interstitial lung disease. And serologically, nearly all of them are positive for ANA. And then the more specific markers are double-strand DNA or Smith antibody, and they typically have low C3 and C4. So clinically, they're quite different. Pathologically, about 20% of the lupus myositis show this perivesicular necrotizing pattern. So this is the HNE, and this is a C5b9 that shows you the necrotic fibers and also the membranous stain in the viable fibers. And most trickily, mix A is strongly positive in these cases. So you can see the strong staining in the perivesicular pattern here. So without history, like on histology alone, it's almost impossible to separate the lupus with a perivesicular injury pattern from the MI2 variant of dermatomyositis. And then the next entity is systemic scleroderma. So this is a systemic disease that most characteristic finding are the sclerodactyly. So that's the tightening of the skin from the tip to and more proximally. But in the earlier stage, it may mimic dermatomyositis or other inflammatory myositis. They have this kind of puffy fingers. They have this Renault phenomenon, and you can kind of hallucinate maybe something that can be imagined as Gaucher's papules or Gaucher changes. They also have these telangiectasia and nail fold capillary abnormalities that are also seen in dermatomyositis. These patients can have interstitial lung disease as well. So there is a pretty good clinical overlap with dermatomyositis and other inflammatory myositis. Pathologically, according to a fairly large meta-analysis that included more than 500 of such cases, it has found that the patient with this PMSCL antibody have a high percentage that show a perivesicular injury pattern on muscle biopsy. So it says that about a quarter can show perivesicular atrophy, and about half of them can show a perivesicular MHC1 upregulation pattern. And they can also have sarcolemma or capillary C5b9 staining. The other antibody variants like KU and UIRMP, they can also be seen these perivesicular damages, but they're less common. And here is an in-house example. So in-house, I've seen about 7 cases of definitive scleroderma cases, and 2 of them shows this perivesicular injury pattern. So here you can sort of see an irregular perivesicular atrophy here. And then the MHC1 shows a somewhat upregulation in perivesicular fibers. And C5b9 here shows just scattered necrotic fibers and very little capillary staining. Typically, the capillary staining in these cases are rare or very mild. And then the 4 differential is eosinophilic fasciitis. So clinically, this is quite different from dermatomyositis. So you see this kind of orange peel-like consistency of the skin, and typically pretty widespread and involve both upper limbs. And these patients typically are negative for any autoantibodies, and they have peripheral eosinophilia. So it's quite a different clinical picture. But pathologically, it's very, very tricky. So as its name suggests, it's eosinophilic fasciitis. But in the case that I've seen, there's very few, if any, eosinophils. And you have these lymphohistiocytic inflammation that seems to be more exuberant in the fascia and then spill over to the myofiber, to the muscle underneath. But you can also see these pockets of inflammation that's deep in the muscle. And on a little bit closer look, you can sort of appreciate there are perivascular atrophy in some of these involved fascicles. And although it's a fasciitis and supposedly secondarily involved the muscle, the MHC1 can be diffusely upregulated like that. So if you don't have the history, these kind of cases are quite tricky. I mean, it's a very difficult case just to call eosinophilic fasciitis on muscle biopsy, and certainly very mimicking inflammatory myopathy. With a perivascular atrophy here, it certainly comes as a differential for dermatomyositis. And here's the C5b9. You can see that there can be robust capillary staining. And thank goodness, the mix A is negative in all the cases that's tested. The last differential I want to mention here is a pretty new entity. It's the immune checkpoint inhibitor myositis. So these myositis typically after 1 or 2 cycles of cancer patient who receive the PD-1 or CTLA-4 inhibitor treatment. And so in this publication that's published in 2023, so this is headed by Andy Mammon in NIH, it collected 35 patients, and 3 of them have this dermatomyositis-like pathology on muscle biopsy. But if you read really close, if you read the full paper, you'll find that these patients actually have anti-TIF1 gamma autoantibodies. And in the patients that have both pre and post treatment serum, these TIF1 gamma actually are present in the pre-treatment serum. So these may truly be dermatomyositis cases rather than ICI myositis, or it might be an overlap case. However, I have personally confirmed or talked with Dr. Bob Bocelli at Washington University, who has seen probably more than a dozen of such patients. He said there is a perivascular injury pattern in a subset of the patients. There they call this IMPP, or inflammatory myopathy with perimesial pathology. And these are images provided by him. So you can see a perivascular upregulation of MHC class 1 and a strong perivascular connective tissue damage. The perivascular atrophy, if any, is very irregular here. Okay, so that's all the 5 differentials that I want to talk about. So in real practice, if you don't have the history, these all present as very significant challenges. And I also want to mention the staining of mix A, which is right now considered a very specific marker for dermatomyositis. I have done my own study, which look at its expression in a wide range of overlap myositis, because I've seen tubular reticular inclusions in almost all of them. And tubular reticular inclusion is also considered a type 1 interferon pathway signal. And so I found that in dermatomyositis and lupus myositis, vast majority of the case will show strong fiber staining. And that sets them aside from all other myositis like antisynthetase syndrome, scleroderma, Sjogren's. They can have a very small percent of case being positive, 1 positive, typically weak. And then for immune-mediated necrotizing myopathy or cloud canal myopathy, they're completely negative. So that's for the myofiber staining. For capillary staining of mix A, it's completely non-specific. You can see it in all type of myositis. And here is a summary of all the differentials that I just mentioned. For the interest of time, I won't go through all through that. You can keep it for your own record. Now I want to get to my third learning objective, which is what I'm most excited about to talk to you today. So I want to discuss the most essential quality of muscle nerve pathology. So neuromuscular pathology, in my opinion, it's completely different from general surge path pathology. So for general surge path, like a tumor resection or biopsy, all the answers are in the tissue itself. So by histology, immunohistochemistry, and nowadays genetic molecular diagnosis, you can get to a definitive diagnosis in vast majority of those cases. For muscle, it's quite different. Muscle, the muscle biopsies, they're rarely pathognomic, meaning there's a lot of overlap between different disease entities. And the diagnosing criteria for these disease entities are contingent upon clinical serological phenotypes, not just on pathology. And then it's a random biopsy, random small biopsy from a huge organ, and the involvement of different muscle are quite different from disease to disease. So it's very liable to sampling errors. So that gives the nature of neuromuscular report. It's often very lengthy because we have more than a dozen histochemical stains to describe, and we may have EM studies and immunohistochemistries and sometimes tease nerve fiber analysis. So it's often 2 to 3 pages long. And the diagnostic uncertainty is just way higher than your typical general surge path cases. So oftentimes we need to consider multiple differentials, and we may need to discuss these differential considerations. And we may need to also point to the clinicians how to confirm by doing further tests. And before I get to what is important in these reports, I want to say what is not to be done on these cases. That is, a purely descriptive diagnosis is not recommended because the clinicians hate it. And this has been well said in a paper published by Enfield in 1920s in a JAMA comment piece. And those are on radiology report, but I think it can apply to pathology as well. So a purely descriptive report is the one that describes the findings in detail, but does not tell you what he thinks, what conclusions he draws from it, and what it means to him. So basically, these reports tells much, yet almost nothing. And it's a perfect word picture, but without meaning to one that unable to interpret it. So basically, the pathology finding is so much minutia. If you just give them the details, it just means nothing to the clinicians. They really need your impression. Now, the danger for pathologists is that when we don't have a definitive diagnosis, if we commit on one, then it leads to wrong diagnosis. Like imagine if on a case of eosinophilic fasciitis, we call it dermatomyositis, on the clinical end, we would look like a complete idiot and probably be remembered as such for a long time. And so that's the danger of wrong commitment. So how do we deal with that situation? So lately, I have had a lot of discussion with Amir Sabori, who is on the right here. So he is a neurologist practicing at a Kaiser Permanente in California. So he gave me this figure that he made. So basically, a pathology report can compose of these 3 components. So there are morphologic findings. Basically, there are the microscopic descriptions. And then we can have a pathology diagnosis. This would be a one-liner that summarizes the pathology findings. This can be descriptive or they can be definitive. And then you can write a comment paragraph which talks about clinical correlation. So this is where you give your impression. You think what is the possible etiology, but you don't give 100% certainty as you give for the pathologic diagnosis. And so what matter to us the most as pathology being correct is that we want to ensure these to be correct. And what matters most to the clinicians are actually the clinical correlation parts. That's what we truly think about. And how do we approach this? So there are 3-component reporting. And because of the uniqueness of neuromuscular pathology, I recommend this sliding scale reporting. That is, the definitiveness of our diagnosis depends on the available pathology and clinical serological information. And when the diagnosis is not definitive, we need to give multiple differentials in the order of from most to least likely. And let me illustrate that to you in a hypothetical case example. So say this is a history we got, 33-year-old female with bilateral thigh weakness and respiratory insufficiency. Lung biopsy shows interstitial lung disease. Rheumatologic workup notable for very high CK and also positive anti-Jo1 antibody. And pathology shows perivascular necrotizing myopathy pattern. So this is a case where every pieces of the puzzle are there. So we can have a very definitive diagnosis as antisynthetase syndrome associated myositis, and given the positive antibody there, given the subtype basically, and a short comment saying that the muscle pathology findings of perivascular necrotizing myopathy in the clinical context of interstitial lung disease and positive Jo1 antibody is diagnostic for antisynthetase syndrome. Now, scenario 2, we still have a good amount of history. We have the age and gender, we have the lung biopsy shows interstitial lung disease, we have the CK levels, just not the serum antibody. Now, in this case, we don't have 100% definitive of diagnosis, but we're having a pretty good idea. This is probably antisynthetase syndrome. In that case, we give a descriptive diagnostic line, perivascular necrotizing myopathy. And we put our most suspected etiology as here, antisynthetase syndrome in bolded sentence. And we suggest to correlate with serum autoantibody to confirm that. And we also raise a few other differentials, systemic scleroderma, dermatomyositis, lupus, and we see they're less likely but not impossible to cover our bases. And in a third scenario, in this case, no history was given. We only know the site and the gender. And then we give the same pathology. In this one, we gave the same perivascular necrotizing myopathy here. And in here, we have less confidence of the actual etiology. So we list out the possible differentials here and give ask the clinician to do further tests to confirm that. So here I list antisynthetase syndrome and dermatomyositis as the first two most likely. And then I talk about the other possibilities. And most importantly, which I haven't started doing but plan to do, is you add this last sentence here. These differential considerations are not exhaustive. If clinical question remains, please contact me, and actually give a reachable number or email there. So this way you can directly talk with a clinician and also give them a way to reach you. And I personally think this is the most important way to reach a definitive diagnosis and also to grow as a pathologist. Otherwise, you're just giving non-specific differentials and don't have a final answer. You can't learn from that. But once you get one, once you talk to the clinician, you're way much likely to get a definitive diagnosis and learn from that. Okay, the second thing is avoid confirmation bias. So we talk about how important the clinical information is, but they're not always correct. Let's look at an example. 53-year-old female presented with Goldschon's papules, subacute symmetric proximal weakness, hand swelling. So these are dermatomyositis-like picture. He also have Raynaud's phenomenon and occasional joint pains. Maximum CK was 1700. myositis-specific autoantibody testing was positive for TIF1 gamma. Okay, so this is seemingly a dermatomyositis case then, even with the serology. So the pathology shows, the second shows an inflammatory myopathy with frequent necrotic fibers, regenerating fibers, and myofiber atrophy, preferentially in the perivascular regions, as well as perivascular inflammation. Perivascular inflammation. So a diagnosis is given, TIF1 gamma positive dermatomyositis. So no obvious problem there. And then later, so because of this diagnosis, this patient underwent cancer screening. So that includes CT scans of the neck, chest, abdomen, and pelvis, and a PET scan. And this was done 3 years in a row. And this patient also underwent a lymph node biopsy identified on the second PET scan, which returned negative for malignancy. And meanwhile, the patient developed mechanic hands, erosive arthritis, and interstitial lung disease. Repeating serologic testing using both prior serum and new serum tested negative this time for TIF1 gamma, but instead positive for PL12, which is anti-syncytase syndrome associated antibody. So the diagnosis now is changed to anti-syncytase syndrome, and the medication is also changed. So this is a very tricky case, right? And what we should learn from this lesson is that the MSA is not 100% reliable. And overall, there are 40% positive rates, positive negative rates, and false positive rates, about 1/3 of the case. And in particular, TIF1 gamma is having the biggest problem. In this brand new paper, when it compares the line immune blot assay, which is the typical clinical assay, and the more stringent immunoprecipitation is more commonly used for in research. When they compare the TIF1 gamma, 8 cases tested positive, only 1 of them confirmed immunoprecipitation. So there is a very high false positive rate in these cases. Almost unacceptably high. So not all pathologists know it. And this is not the only MSA that's not very specific. So how do we deal with that situation? So my suggestion is that you use a cold turkey approach when you read the slide. So not to be influenced by the clinical history, you don't read the clinical history when you first look at the slide. You look at the slide first round with just pathology and form your own idea. And then you read the history and put them together and come up with your own differentials. So that would be the recommended way to approach that. The third point I want to talk about is that looking back at this case, the pathology, which actually from the description is a perivascular necrotizing myopathy. Now, if you remember from my talk, that would be typically seen in MI2 variant or the anti-syncytase syndrome. So and TIF1 gamma doesn't show these necrotic fibers. So if you know that, you can capture that earlier. Third point, does clinicians understand your hedge words? So look at an example, 63-year-old man with history of poorly controlled diabetes present with intractable right thigh pain, progressive swelling for a few weeks. MRI shows diffuse edema, CK was normal. And the pathology shows moderate to marked variation in myofibers, edema, a few probable necrotic fibers, and a few small endometrium perivascular clusters and the diagnosis is fairly long, scanty patchy chronic inflammation and focal and blah, blah. But here's the correlation. The histology features are compatible with those in diabetic muscle infarction. Now, if you show this to a pathologist, most of the pathology would know this is a very weak and equivocal diagnosis, and they use the term compatible with. Now, I don't know what's your experience. From my own experience, we
Dr.
use.
Cai,
Yes.
per your request, it's 12:50.
Okay, thank you. I'll
You're
speak
welcome.
from here. So consistent with means, the pathology is typical for this entity, but I can't exclude others. And compatible with was an even weaker description. That means, well, this entity can look like this, but it can also look like others, and other entity can look like this. So it's very weak diagnosis by pathologists. But does a clinician understand that? Clinician's feedback is patient clinical presentation was not consistent with diabetic muscle infarction. No differential diagnosis is provided reflecting the pathologist's high confidence. So here, clearly, the clinician completely ignored the word consistent with compatible. They don't know the meaning behind that, or what we mean behind that. But giving only one diagnosis is indication of high confidence to them. So that's what they interpret as we interpret it. And so for this particular case, this diagnosis is not good for the patient because it's a non-treatable condition and it will delay treatment. So lesson learned is that a single diagnosis without alternative consideration is considered high confidence by clinicians. And the clinicians may not understand what consistent with compatible with means. So you have to make sure they do, or you use some other words. And if pathology is not specific, state so and provide differentials. Point 4, that's my last point, understand the treatment of implications. For the interest of time, I won't go through the whole scenario. So, but basically the most important thing is, if you are indeterminate between two differential diagnoses, one is treatable and the other is non-treatable, give a little bit more weight to the treatable condition, because that's very important. If you miss that one, or if the clinician missed that one, the implication is very big for them. That might be a lawsuit. But if it's a non-treatable one, the consequence is much less. So give a bit more weight to the treatable side, or err on the treatable side. Okay, so here's my summary slide of today. I covered the 5 dermatomyositis subtypes, which separate into 3 morphologic subtypes: periphysical necrotizing myopathy, periphysical atrophy, and near normal. And then I cover 5 differential considerations. And I also talk about some suggestions for how to write our pathology report. And here comes to our Q&A session. So please post your questions in the chat.
Yes, thank you, Dr. Cai. So at this time, we'll move into Q&A. Please submit via the chat box or unmute to ask a question. When submitting via the chat box, please ensure the message is to everyone so that everyone can see it. And to unmute, select the microphone on the lower left. And after you've asked your question, please remute. Dr. Cai, would you like to read the questions yourself from the chat?
Yes, okay, sure. So first one from Dr. Cohen. I thought that perivascular damage was a sign of border zone ischemia. If this is not the case, do we know the pathogenesis PFA? Thanks. Okay, this is a great question. This is a question that has been puzzling us for like a decade, or no, I'm probably a century. But we don't have a definitive answer. But the current understanding is, yes, there is a correlation between the vessel and the atrophy. As I show you in the avascular paramecium, that's where you see the atrophy. Those are the area that's most distant of the feeding vessels. So yes, there is a correlation, but that's not the only cause. You also have another cause, which is probably from the paramecium region. And that's where you see the MXA positivity there. So the inflammation signal is most concentrated in the perivascular region. So that also contributes to the myofiber atrophy or other pathology. So I hope that answers your question. And you can clearly see in these different subtypes, the targets are different. For the MI2 variant, the injury or target, it's much more focused on the myofiber, causing myofiber necrosis and damage. And on the NXP2 and the TIF1 gamma variants, it's much more focused on the capillary or the larger vessels. Okay, so next question. Could you please comment on lymphocytic patterns in different types of DM? Some of example look more necrotizing with very little chronic inflammation. I was wondering if this is often the case for certain subtypes. So, there are the Japanese group study published in neurology have better assessment of that. So in general, for the MI2, TIP1 gamma, and NXP2, these are the ones you can see significant myopathic changes. They share the similar inflammatory pattern, which is dominated by perivascular perimysial inflammation. And that is contrasting to the traditional polymyositis or IBM, which has a predominant endomysial pattern, right? From a case-to-case base, you can't really assess which subtype has more inflammation, which subtype has less. So I don't use that as a criteria. Again, as I said, I think if in terms of immunostain, C5b9 is the most useful to differentiate them from each other. Yeah, I think that's pretty much. One tricky thing is that for most of the overlap myositis or rheumatological diseases, their inflammatory pattern is also most commonly perivascular. So having a perivascular inflammatory pattern does not give you too much information, in my own opinion, to separate dermatomyositis subvariants or from other myositis. Oh, I don't see other questions.
Oh, actually, can I ask a really quick question?
Yes.
So, the four, when you classify for GM, ACIS, IMNN, IBM, that is not in the current edition of Robbins. Do you think it's going to be in the new edition? And do you think a year 2 medical student needs to know this?
That's a very good question. I actually teach the muscle lessons to PC2 medical students, and I do teach them that. I don't think it's in USMLE 1, and it's not in Robbins, as you said, but it definitely should be, especially we are much more confident and much more well studied and researched in these fields now. So I think, but the tricky thing for neuromuscular pathologists is that there is no who book series. There is not a one single go-to place for all neuromuscular pathologists. So we don't even know where to publish these, right? So,
Yeah, but I mean,
so ENMC is where I go to for these recommendations.
Okay. And I do think you did get another question.
Oh yeah, I'll read it out. Is the peripheral eosinophil count in a CBC or cell differential helpful for identifying eosin? Yes, absolutely. So as I listed in the PowerPoint, 60 to 90% of those patients had peripheral eosinophilia. So clinically, the key is that clinically it's not difficult to sort these patients out. Pathologically, if the pathology have access to the clinical information, yeah, definitely check that. That will be very helpful. But if you have access for CBC, then you probably have clinicians note, then you know much better. In fact, these cases, the biggest clue to pathologists is that when the submitting surgeon or clinician submitted on your path report, they would actually maybe put on that their clinician, their top differential is eosinophilic fasciitis.
Then I think I don't know if you want to try to squeeze in one more question. Howard Chang, do you do immunohistochemistry reaction only on frozen, on paraffin, or both?
Excellent question. So for each antibody, if you want to do them, you have to validate individually. So for our institution, when we validate the MHC1, it's on frozen section, so it's always done on frozen section. For the mix A, I validate on both paraffin and frozen, so they can be done on both. And in my own personal experience, mix A works best on paraffin sections, better than on frozen. And the MHC2, I'm in the process of validating it. It stings less definitively than mix A or MHC1. So I mean, yeah. So it has to be your own institutional process that you get a feel what works best for you. Oh, is there one new message? Does genetic analysis have any role in diagnosis? Well, so absolutely for the hereditary conditions, right? For muscular dystrophies, for a lot of the hereditary neuropathies, those are nowadays first line diagnosis. What we often deal with is that we have a case with equivocal findings, VOSs, or genetic study find nothing, but clinically they still strongly suggest that's the time we gets it. So the pathology nowadays are much less specific. We don't see the classic cases anymore. We see all these equivocal cases. So so it's becoming more difficult for us, in fact. But yeah, so genetic analysis has a huge role in hereditary diseases. And for inflammatory myopathies, the serology is playing more and more important roles in the diagnosis.
And then one more thing, Maddie, can you please post CME information? I've got it in a request for it, and let it sit there for a minute so people can access it if you can do that.
Are you wanting just the link for the survey, or?
Someone says, can you please post instructions for CME credit? That was the request.
Yeah. So what I can do is post the paragraph I'm about to read.
Yeah.
So thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and select your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Cai for an excellent presentation. This concludes our session for today, and then I'll go ahead and post those instructions and stay on for a couple of minutes for anybody who wants to maybe copy them out of the chat.
Thank you, Dr. Cai.
Thank you.
And we'll see everybody in Tahoe, right?
Yeah, see you there.